And I think your presentations have aroused many questions in many of us. I will grab the opportunity to ask you the first question. I think we all know this is just a predictive tool. We all know that we get some information, but sometimes I think that it may become a bit difficult to handle the information, especially if we have embryos in the gray zone, so embryos that have not the best prediction for implantation, or embryos that don't have the best prediction for euploidy. So we sometimes face patients saying that, okay, doctor, we have another 6 embryos. Some of them don't look very good to give us a pregnancy. They don't probably have a very good implantation rate, or the rest don't have a high score for euploidy. So do we just go ahead and do another IVF? Do we use them? Are we going to do PGT on frozen embryos? So what are your thoughts and experience on this?
So that's a good question. And what we usually recommend clinics is AI can never take the place, can never replace the human expert. And what I believe as, working with these models or different models for so many years, I think it's always complementary. So my suggestion, my recommendation is to apply a model on top of a model on top of a model. So at the end of the day, if you have 5 embryos, 6 embryos, and you apply the IDA score, and you apply AIVF score, and you apply the genetic score, model on top of a model on top of a model, at the end of the day, you reach the 1 or 2 embryos that has the highest chances, and the highest chances above, again, 85 or 90% accuracy. If you apply a model on top of a model on top of a model, and this recommendation was actually presented, I would say, more than a decade ago, when we first started working with the embryoscope and the annotations. We had we asked the embryologist to grade, and then we added the annotations. So it was over the embryologist plus the annotations. So this is what we're saying. First, the embryologist grades, then we add the different AI layers, and then we have a decision that is much more data-driven. And this is one aspect. The other aspect, I think, this gives us a way to communicate to the patient the real dilemmas and the real situation. We're not selling illusions. We say these are the truths, or these are the dilemmas. Now we make a decision together. And the fact that she's engaged and she's part of the problem, part of the decision, she understands. This makes her much more I would say much more compliant and to the process and to the clinic. So this is my recommendation. And one more thing I would add before Professor Zeidman. It's at the end of the day, it's also a question of how the specific clinic works. So it's based on the protocols of each clinic. Some clinics, see the models, use the models, and and freeze. Some clinics really do take the next level and actually discard the embryos. So it's pretty much based on the protocols of the clinic.
Just wanted to add that, again, as a physician, we're very much aware of this problem of communicating to the patient. We actually developed a module where we calculate predictions in a very graspable way for the patient. So the doctor gets a report which tells him, if you put back these 3 embryos, your cumulative chances of pregnancy are 60%, and your chances of miscarriage are 30%, and so on. So because we're getting more and more data, and you implied that, and you're correct, we're also developing in the same time tools that integrate all this information and also show it graphically, so the patient actually gets a report, because my patients hate it when they're told, oh, we put back a great looking embryo and we also frozen some really lovely embryos, and they have no idea what this means, okay? She's 42. What does a really good-looking, high-quality embryo means when she's 42? And they felt misled because last month you told them that she has really good chances. You implied, you told her you have great embryos, and now you sit with her and tell her, look, you're 42. Seriously, you have a 10% chance of having a baby. So I think that these new tools that we developed, and I think Hegea will be acquiring them, will really help us kind of integrate this mass amount of data. And the things are only going to get worse because, as Daniela said, we're going to have more and more algorithms, more and more data, but in the same time, I think we'll have great tools to integrate it.
Very good question. Thank you. First of all, thank you very much both for the very comprehensive presentations. According to what has been said before, and according to the data of the latest systematic reviews, the aneuploidy or euploidy detection rate for all AI models is around 70%. Okay. I would like to ask, given that the learning curve of AI models is impressive, how far are we from reaching sensitivity rates closer to reality, and how this can affect the number of embryo biopsies and PGTs in the future?
Well, sure. Look, first, these programs are all the time improving because in order to improve AI accuracy, you need more and more variation, which means more and more data. So clearly we're improving. But we'll never reach 100% of PGTA, so that's not the question, not also the goal. There's a lot to say against doing routine PGTA, and we know if you take a 25-year-old patient, why would you need PGTA? And probably the same can be said if it's a 44-year-old patient, probably PGTA doesn't make sense. She has two blastocysts and you damage them. And actually I can tell you that since we look a lot on data, centers telling you PGTA does not damage the embryo, we just take 10 cells and we freeze them, and this really makes them very vital. That's not true. We have data showing, and we don't want to publish it because we don't want to get into a bad position with these clinics, but there is a negative effect for PGTA. So in the end, I think first, already at this moment, it's very valuable. If you have now 4 very low, medium to low quality embryos, and the patient is paying for freezing them, and the program tells you that there's a 10% likelihood that there are 90% chances that they're aneuploidy, this can help you in making clinical decisions. And also it helps you a lot in advising the patient, because if you tell a 42-year-old patient, look, we can predict that you have a 5% chance of having an aneuploid embryo, this helps. So I don't think we'll ever reach 100%. I'm certain we'll have models reaching 80%. Again, you have to look at different populations and so on, but I think already it's a very helpful tool, and it will become more and more part of our ornamental. Again, maybe everybody will be doing PGTA, but again, there are limitations, both cost and legal for this.
Yeah, I do want to touch about PGTA. I can tell you that from the data that we have, 30% of patients does not want to do PGTA for different reasons. So for these 30% of patients, we don't really have anything to offer right now, until IVF genetics. But this is, I think, a good tool for these 30% of patients does not want their embryos to be biopsied. I know I wouldn't want my embryo to be biopsied. So this is a very good indication, or an indication layer of what's the status of the embryos. This is one aspect. The other aspect is, even if I do PGTA, the fact is I actually go home and I have zero understanding. I have no way of knowing what would be the status of the embryos. So I go home, The embryos are subjected to biopsy, sent to a PGT lab, and then I wait. So for these patients, those patients that do PGTA, offering AIVF genetics could be, could really reduce the uncertainties and reduce the stress. Why? Because she's being sent home, but she actually knows what the status of the embryos might be. If the embryos are high likely to be euploid or aneuploid. Even if she does want the embryos to be biopsied, she's not going home empty-handed or without understanding of what to expect. So this, reducing the uncertainties in an IVF process could really, again, create much more compliancy and retention. This is from the patient side. Model side, it's all about data. And I think the fact now that we're over a decade using time-lapse and we have more and more data, data is gold. And the fact that we have to do data-driven decision-making in IVF, this is something that I go on each and every stage and I talk about data-driven decision-making in IVF. We have so much data being generated in IVF clinics today. We have to start using it to make better informed decisions that affect the overall treatment.
Thank you very much.
I think that clinicians and embryologists have to be trained alongside the AI systems to get used to them.
This is interesting. I do have to say that we conducted an interesting study, and we've shown that it's not about AI versus human. It's always the team of AI and human. And we've shown that if AI and humans together as a team, work together as a team, so it gets a better performance than AI alone or human alone. So it's always the iterations between us as humans or domain experts versus with the AI to make the best performance.
Any questions from the audience? Vaya.
Hello, thank you very much for the nice talk.
You need the microphone.
Thank you very much. It was very nice talks. So at the previous talk, there was a gynecologist that was talking about AI and ovarian stimulation. And at the end of the presentation, she asked ChatGPT, will AI replace me? And ChatGPT answered, of course, no. So I'm answering according to the fact that this year, on May, it was born the first AI IVF baby from the automated system Aura. That's a combination of robotics and AI. So my question is, if I ask ChatGPT today, as founders of an AI algorithm, what do you believe will answer? Will AI replace the embryologists? According to the fact that the baby was born. Both of you.
So I don't think so, actually. No, I think we're far away from a pure 100% automatic lab. I think it's an amazing idea. I think it's visionary, but I don't think it's in the next 5 or 10 years. And the reason is, medicine and embryology it's not a thin layer of knowledge or a binary yes or a no. So again, as I said, I think it's far away, the ecosystem or the industry is far away from having a 100% pure automatic lab with no embryologists, human embryologists, just robots. This is a nice pitch, startup pitch, but I don't see it come to life in the next 10 years.
So I'll have a job for the next years, I think.
Yeah, no.
We all are going to have a job.
A question.
It's interesting asking ChatGPT because, will we ask AI, are you going to take over the world? And he say, of course I am, be aware. He'll probably be smart enough to tell us, no, don't worry. So I think in the short term, a lot of companies of automation or robotics are exaggerating. We worked with a company that does sperm selection and injection. And again, if you have a perfect sample that you wash it and it has nice sperm, it works in demonstration beautifully. But if you've looked at sperm samples over the last few years, you know that some of them are contaminated, some of them are dense. And so the real world is very difficult. But on the other hand, and also we've been promised automated cars, right? Elon Musk 80 years ago said that in 6 months we'll be driving automated cars by themselves, and they're not. On the other hand, we have these taxes coming in. So I think in the short term, these companies are over-promising, and it's going to take at least a decade or two. But it's clear that in the future, a lot of this will be automated, which means that embryologists will be doing different things. You know, instead of doing ICSI, they will be doing much smarter things. But that's fact. You know, AI is going to take most of the jobs of physicians too. So, but fortunately, probably not in our early lifetime. So.
Comment by Dr. Anagnostara. And then Professor Makrakis would like a comment.
My question is more about routine embryology. So how would you manage a patient consultation if you had embryos that had high implantation scores, but then their hemogenetic scores were higher for aneuploidy? How would you handle that?
High IVF, high implantation. Yeah, that's a good question. We actually now have a combination score that takes into account both scores with different ratios and provide a good consultation tool. Yeah, but it's basically a way, as I said before, applying a model on top of a model to help you, at the end of the day, select the one. Okay?
So would the hemogenetic score count more?
Yeah, the hemogenetic score count more because it's based on prediction of implantation, and we added the age, and we added the prediction of euploidy. So it's an integrated model it's an integrated model. So I would go with the hemogenetics. But again, there's now also a consultation tool to help you communicate the different dilemmas to the patient. And one thing I do have to say, and this is something that Professor Zeidman can add as a physician, don't forget that these models were trained or are trained to look at the embryos. But the effect of the patient or the data of the patient needs to be added to when consulting a patient. So you can say, this is the status of the embryos. But what are my chances as a patient now in this clinic? So it's kind of like a personalized IVF care or personalized medicine. So the models are looking at the embryos, and then the consultation is me as a patient, what are my chances now in this clinic?
Danielle mentioned, which we found very interesting, that the embryologist contributes to the use of these scores, which mean that if we talk about automation, I mean, should we just trust the score? No, we saw that you have a good embryologist, and he has this additional information, he makes better choices. So you're right that we should give just one score and throw away the two scores that we're providing. But actually, we found that the embryologists know how to use it. Clinically, they can reduce miscarriage rates, which we told in one of the clinics. So this is additional information, and embryologists, some of them at least, know how to make sense of the decisions by knowing if this is high aneuploidy, and also I saw a lot of fragments, and also I wasn't sure if I saw 1 PN or 2 PN. I can make these decisions, okay? And I think any experienced embryologist sometimes looks at the embryo and says, oh, I looked back, I'm not sure if there was a polar body, I'm not sure about the symmetry, I think there was direct cleavage, I have a bad feeling or a good feeling. And when you have support from the system saying, oh, this is also highly likely to be haploid or aneuploid, it helps you understand what you're looking at, because I talk a lot with embryologists every day, and they always give me this second sense. And some of the embryologists I don't trust. Some of them I know if she tells me this will implant, although it's a BC quality blastocyst, I trust her. And this is some intuition. So I think having this additional information improves your intuition. And we have some proof to this. It's not just hearsay.
It will be interesting to see how the systems evolve and how precise they can become in the future. Thank you.
The last two comments, Professor Matzavinos, and a closing remark from Professor Makrakis, please.
Congratulations, both of you, for your excellent presentation. So interesting. Before my question, I want to say congratulations, representing the doctors of assisted reproduction in Greece. Really, my congratulations, this excellent meeting of VIGIA and Embryogenesis and the organizing committee. And these meetings put the level very high, and we're very proud, and they help us, also the work in VIGIA and other centers. And we're very proud to believe that we are at very, very high levels all over the world in IVF. And now my question is, starting for these magnificent things for the artificial intelligence, from the sperm, from the oocyte, from the embryo, the growing up, whatever, how far you think we are from the time that the embryo will grow up in the lab for 9 months, and then the mother will take it from the lab? Or maybe this question will be, I will ask it also, or maybe he will ask Professor Stratakis, who is always looking in the future. Okay.
Yeah, I can, first, I'm sure we'll have an artificial embryo. I doubt if I'll see this being alive. Because I have only a few decades future. There are a lot of labs working on this. There was even some hosts from Japan hoax that they said that they're putting out this machine, which was of course ridiculous. People are now working in culture to have artificial placentas, and there's a lot of work in Japan where they're putting the babies in artificial amniotic fluid instead of on respirators, and this is working, and they're now trying to, they haven't yet applied it to babies, but it works nice in an animal model. But we're very, very far away. Although I'm certain that you have a really valid point, because this will happen, but it will be decades away.
Thank you, thank you.
I do want to add, there's interesting work done by Jacob Hanna, so you can look him up. And he's now shown that he can grow, I think, mouse embryos to the stage of, I think, third of the pregnancy of it. Yeah, third of the pregnancy already inside the lab. So it's very interesting. I think we're closer than we think to doing this in humans. So Jacob Hanna, someone to look.
A closing remark from Professor Makrakis.
Firstly, I would like to thank you, not only for the presentations, but also for collaborating with us. We are very happy to collaborate with you. And I mean, I want just a very simplistic question. For all these years before AI, we were used to grade the embryos for AA, for AB, and also giving some chances, possibilities for implanting. After implementing the IMA, let's say, initially, what is the rate of discordance between the previous traditional system and the new system? I know it's quite simplistic, but for example, if I had an embryo that is 4BB, what is the chance of you giving me a better rate than the ones I used to know for a 4BB embryo? This is the discordance.
I could tell you that we increase success rate significantly, and we've shown it in each and every lab we go into. This is based on labs following or clinics following our recommendations. But a 4BB in one clinic is not like a 4BB in another clinic, and it's not even like a 4BB in the same clinic, but at a different hour in the day. Because basically it really depends on who is scoring it or who is grading it. And the variability between embryologists even in the same lab is huge. What I see as a medium-looking embryo or a B embryo might be regarded as an A embryo by my peer, or even as a C embryo by a junior embryologist. So I think this is the problem. It's a very subjective human analysis.
But you have our data. So what
oh,
have
in
you
your
found?
data?
Yes.
Oh, okay. So yes, sorry, I thought high level. So yes, we see increase in success rates and implantation rates. We also see reduction in time to pregnancy, which is a very interesting matrix as well. So yeah, so I suggest use it more and more and more.
I would like to comment on that, and I totally agree. In cases like these, which are not rare in the lab, you have to find a balance between reducing the variability of embryologists and at the same time using the experience of the embryologist. So a 4BB for me might be a 4AA for Kostadina, for example, but it will always be an 8.2 for AI, no matter how many times the system sees it.
This is why I'm asking this.
So we know that AI has almost perfect consistency, and embryologists don't. But embryologists may bring in the experience from analyzing a case by looking at the bigger picture. So we know that AI can be complementary, as you said, so we can have a very good decision-making assistant. So the final answer, I think, still lies with how the embryologist is going to use this information.
Daniela and Danny, thank you so much for the excellent collaboration that we have in this first year. You know that one size does not fit all, so calibration is something that we had to perform as well. We were able to publish 5 abstracts during the last tertiary conference in Paris, and we're really glad about that. We look forward to developing our collaboration by providing all IGEA patients your service, and we look forward to the next conference 1 year from now.
We do a grand presentation at the next ASH together.
Thank you very much.